last speech and language therapist that you're coming across today. And we're going to be talking about swallowing disorders, which is probably one of the less known kind of responsibilities of a speech and language therapist, but I'm going to be talking through briefly why we're involved, what we look at, and how we can help. So just to start off with, talking a little bit about why we're involved. And eating and drinking is much more than just swallowing. So we come in and we look at if there's a problem with it, but we have to consider that swallowing is part of it, is a very small part of an experience that makes part of life quality. It plays a big role in events such as birthdays, such as Eid, Christmases, weddings. It forms kind of the basis of a lot of celebration in life, and a lot of our relationships center around meals. It gives us joy, pleasure, memories, forms part of who we are as a person, our likes and dislikes. So when we're looking at eating and drinking, we can't ignore the fact that it is what makes us who we are, and what involves us in our personal culture and identity as well. We get involved when there's something that goes wrong with the eating and drinking experience, and specifically swallowing. The word for this is dysphagia. So it's kind of a medical term, and you see the word DYS, dys, in a lot of medical terminology. It means difficulty, and the phagia section means eating. So dysphagia, difficulty eating. There's a lot of causes that come behind dysphagia, and we're going to talk a bit about what they could be. So broadly, you can have developmental causes for dysphagia. So this can be difficulties with your swallowing that rise from birth, from growing up. So any congenital conditions such as cerebral palsy, cleft lip and palate in children. So the difficulty then with your lips and with the palate in the top of your mouth. And with neurodiversity, so autism spectrum disorders and other emotional behavior conditions that make the eating and drinking experience difficult or limiting for the person. You can also have causes of dysphagia that are acquired. So these come later in somebody's life, previously typical and now new onset difficulties as a result of neurological conditions. So these are things like traumatic head injuries, strokes. They could be cancers in the brain, but also head and neck cancer then, that are coming a bit further down, that affecting kind of the movement, respiratory conditions such as COPD, that the weakness that you kind of get with a more elderly swallow. So weakness then with your swallow orally, but also then down into your throat. And it can also be a side effect of some medication. So you can see dysphagia rising from lots of different causes, and we can be involved in any of those, both in pediatric and in adult caseloads. So just to kind of set the scene of a swallow, there's lots of components that come into what makes the swallow work, and it's really clever how our body does this. So we've got labeled 7 kind of key features there. So we've got number 1, which is the teeth. So that kind of sits quite front in the mouth, and then we've got our lips as number 2, tongue's number 3 there. Number 4 is a structure quite far back below, so right at the bottom of the tongue. That's called your valleculae. So that kind of catches the food or the drink as it comes back. And then a bit further down, number 5, there's a little kind of pink sliver below the line, and those are our vocal cords. So those are the bits that vibrate to make the sound of our voice. And that kind of sits at the very top of number 6, which is your trachea, your airway. And number 7, just behind your trachea and your airway, is your esophagus. So all of these different components for a typical swallow work in perfect harmony to make it safe and to get everything going down the right way. It protects the airway and it opens up the esophagus so that it's all your food, drink and saliva can all go right where it needs to go. When we get involved is when things don't quite go in the right way. That can happen in lots of different stages. So when we can thinking about a swallow, there's 4 different main stages to a swallow. So there's the pre-oral stage, as you can see. So we're looking at the food, we recognize it as food, we can smell it, we think, oh, you know, that's my favorite, you know, sauce on that food, or oh, that looks like a really nice thick gravy or something. And our body prepares for it. We start to salivate, we might start to have a rumble in our tummy. We then get to the oral stage, which is when the food or the drink is in our mouth, and we form what we call a bolus. So our tongue and our teeth move the food around and form it into a nice ball all together. And in that oral stage, we keep it in our mouth. We don't let it go anywhere. We keep it trapped. Then we push it back and we pop it into the back of our throat, just behind our tongue. And this is in an area called your pharynx. So it's called the pharyngeal stage. And then it becomes more of a reflex. We have less control about what happens in the back of the throat there in your pharynx, and the food begins to move down. And we protect our airway. We cover up our trachea with our structures there. And then it goes into the esophageal phase, down into our stomach. So there's things that can go wrong in one or multiple of these different stages. And we're going to talk a bit about how we figure out where there's any kind of difficulty and assess for what we can help with. So when we're assessing any kind of swallowing difficulties, these are the main kind of tools that we have at our disposal in speech and language therapy. So we might start with a case history. What's the person's background? Where have they come from? When has this begun? And what has been the previous kind of experience for this person? We might speak to if there's any medical professionals involved and family as well at this stage. We might then also do an oromotor assessment. So we're looking at how all of their structures are moving and what their sensation is like, to see how their cranial nerves that control the swallowing are doing their job, and if they're not, why aren't they, and what's going on there. We'll also do a bedside swallow assessment if that's indicated. So we'll try different textures of food and drink to see if things go well or are more difficult, to see if there's any pattern there. We might also have a look at them over the course of a whole meal. So kind of observe what's happening, have a look at their position, have a look at what's happening over a long period of time. Do they take a long time to eat? Are they leaving things out? And then to kind of look in a bit more detail, we have options for what are called instrumental assessments. So these are assessments that require pieces of equipment to complete. And there's two different types. The first is fiber optic endoscopic examination of swallowing, and the second is a video fluoroscopy, or sometimes we shorten that to VF. These are two different types of instrumental assessments that I'm going to briefly touch on now. So the first type we're going to talk about is a video fluoroscopy. So a video fluoroscopy is an X-ray video of somebody swallowing when they're sitting on their side. I'm going to show you a brief clip of what this looks like in a moment. While I'm talking, you can watch. I can make it play. We'll see if that goes. Essentially, we can see the side of the person and we give them something to eat or drink. We then watch that track into their mouth and down into their esophagus. And we can see if that's going all the right way or if there's anything that isn't quite going the right way. Let's see if I can. Apologies, I can't get that video to play at the moment, but you can see the structures for this person. They have their teeth on the left side of the screen there in the darker colour, their jaw there coming just below the teeth, and then you can see in the back there, the lighter patch is the open airway. So this really just helps us to learn a bit more about their airway protection and to see if some textures of food and drink are safer than others. There's a second type that we then look at, which is our fiber optic endoscopic examination of swallowing. So here we've got two lovely volunteers on the left showing you how it's done. So this is a camera that is on the end of a scope that we insert into one of the nostrils down to the back of the throat. And it allows us to get a video in colour of the inside of somebody's throat. So as you can see on the right there, we've got a labelled airway essentially. So this is just, if you think about your own mouth, just at the back of your throat below your tongue. So if you go down and back, and you can see in the video where there's a big bright white dot in the bottom right corner, that is the bottom of the person's tongue leading into this structure called the epiglottis. So that's the front. And at the back, you've got this space here, which is called the posterior pharyngeal wall, which is the back of their throat. And then very clearly in the middle, you can see this lovely clear V shape, and that is the person's vocal cords at the top of their airway. So we would use this as a way to see if they're keeping their airway clear when they do a swallow, and if they're not, what's happening. so we can go know a bit more about it. So once we've assessed what the problem is or could be, we then look at trying to see how we can help. And that would involve lots of different treatments or ways of managing it. It obviously depends on the nature of the dysphagia, the swallowing problem, or how severe it is for the person. And also need to consider how much nutrition and hydration the person gets all in all. So eating and drinking is more than just the lived experience of it culturally and socially, but it's on a very biological level how we maintain life, and we need nutrition and hydration to live the lives we need. So for part of the picture, we have to also consider how the person gets enough nutrition, enough hydration, and that's where our dietetic colleagues come in, but I'll talk a bit more about MDT working a bit later. For some people, they need support to do that through gastrostomy tubes that go into their stomach to provide the right amount of nutrition and hydration. But ultimately, we need to consider what the goal is for the person. Are they eating and drinking for nutrition and hydration to get as much as they can orally, or is it for pleasure? So that kind of would dictate a large part of what you're working towards for the person. One way we can do that is have a little look at what we can do with the meal itself. So we can change the texture of the food. There's 3 different types of food there in this slide. So it starts from the one on the left, which says level 4 pureed. So these are very smooth foods, no bits, and they can be eaten with a spoon. Level 5, a step up. So the higher the number, the chunkier, if you like. So that's minced and moist. And that's got kind of small pieces, but a bit more broken up. And level 6, soft and bite-sized. And this is all just about texture. You can have any food as long as it fits these texture requirements. You could have a carrot that could be a puree, level 4, minced and moist, level 5, and soft and bite-sized, level 6, as long as it's prepared in the correct way to be the right texture. So this is just one way to modify somebody's diet. We can also modify the texture of their fluids with one of these examples here, prescription thickener. So this is a substance that can make drinks thicker to a certain level. And that can be helpful for some people with a dysphagia. It can make it easier, but it's not a kind of a solving factor for everybody. All of the kind of descriptive measures we use for the texture of a drink or food is dictated by this framework. So this is an international dysphagia diet standardization initiative, which is a real mouthful. So we call it IDSI, and essentially IDSI is the descriptive measure that's used internationally to describe the texture of a drink or a food. And these are dictated by the speech and language therapist based on assessments and on the context for the person. So this is how we would manage at the meal time and maybe on the oral intake side, but how can we help in terms of treating the dysphagia itself? So there's dysphagia rehabilitation exercises that can be appropriate for the right person, depending on what type of dysphagia they have. So that can include exercises that improve the strength or the coordination of somebody's swallowing, and also are done alongside functional swallowing exercises. So they might have eating and drinking with a speech and language therapist to practice certain strategies, such as doing a really strong swallow to incorporate into their more functional work with a swallow and making it easier to do that. But alongside this, you can compensate in other ways. So you can compensate with the use of the right equipment. So there's things like cups that control how much drink comes out at once. There's cups such as the one on the left called a nosy cup, which means that you don't have to tip your head to get the cup to have all the drink come out the way, because otherwise your nose would get in the way. It's got a little gap so that you can tip it all the way without your head going too far back. And you can change the positioning of the person, so you can help them to bring their head forward to do the swallow. Or in this picture here, we've got some clinicians with a person to make them in an upright position and supported there at the front to help them to be nice and safe for a swallow. If you change your position and try and swallow in different positions, such as laying down or looking up at the ceiling, you'll experience that it is significantly harder. So sometimes compensation strategies can help a great deal for someone who's experiencing dysphagia. if these things aren't optimized for the person and they haven't got the right recommendations, there are some really high risk scenarios that can come from having a dysphagia. These aren't limited to the risks that you can see here, but these are kind of the main ones that we really highlight and look at. And this is why assessing someone's dysphagia is really important, and it's really key role for a speech and language therapist. So first and foremost is choking, coughing and discomfort with food and drinks, aspiration pneumonia. So aspiration means anything, saliva, food or drink going into the trachea, into the airway and into the lungs. Obviously, it's not meant to be there, so that if it would take lots of bacteria with it, and that can cause a pneumonia, a chest infection, which can be fatal in some cases. It can reduce the quality of your life. Obviously, we've talked a bit about how culturally and socially eating and drinking as an experience is really key to some of those big moments in life, but also just day to day. It's a normal thing we do. They might have less social opportunities, and they might have malnutrition and dehydration from avoiding foods or not being able to get enough to eat because they have such a significant problem. And also it can cause behavioural changes. It can cause the person to be present in a different way than they might otherwise be. So optimization is really, really key, and it's obviously it's a quite a big role for a speech and language therapist in some areas. But it isn't the speech and language therapist alone that would be responsible for helping someone with a dysphagia. We rely very heavily on a multidisciplinary team, so with other kind of professions and other disciplines to ensure the person that you're helping is really optimized and safe and living the life that they want to. The dietitian role would support with helping the person with nutrition and hydration, as we talked about earlier. So any extra nutrition and hydration through tube feeding into the stomach for the person, but also for supplements that fit the right texture modification if needed. Doctors and nurses obviously are crucial, so really important for optimizing the person medically, for monitoring their health status, and especially if this person has a case history that would lead them susceptible to chest difficulties. The medical team and the nurses are so crucial. Physiotherapists support with positioning and posture to make sure that, again, the swallow is really safe, but also so the person can feel more able to engage in that activity. And finally, occupational therapists. So these are therapists that support with the equipment and the access to the task. So they would help support with how able someone is to feed themselves, how able they are to engage in the task cognitively, and how they can use their senses to experience the task as well. So using their vision and their attention to kind of be in the moment with a meal, eating or drinking. It's been quite a whistle-stop tour of swallowing, and there was a couple of videos we couldn't look at in more detail, but ultimately a dysphagia caseload and looking at swallowing from speech and language therapy is very, very, very varied. Obviously, we're speaking here from a perspective of therapists working with adults that have had brain injuries, but this is a caseload that you see across all areas of speech and language therapy. So yeah, I hope you've learned something interesting about this area or something new you didn't know before. And that's everything I wanted to talk about for this evening there. So if there's any questions, then I'm all ears. Thank you very much.